Well, this is actually very informal, so I know you've got Q&As afterwards, and please feel free to stop me. What I've done actually is take a few of my slides, so I'm not patronising of using the same slides that I used. Some of them I used at the International Liver Congress, where we managed to persuade the International Liver Congress to have a session on PSC, and actually that's a similar session that we actually managed to have the International IBD group to also have a session. So I want to just cover thoughts about PSC, and as I said, just stop me as you go. It's a challenging disease, okay, but it's probably the most exciting time in PSC that there's been, because there is more industry involvement in new clinical trials than there's been in 100 years, and we actually run the risk of having more trials than we can actually conduct, which is actually a better thing, and I'll come on to that near the end, because in the real world of getting new medicines to patients in the 21st century, you need about 10 stabs at a go to get one drug that becomes the wonder drug. So we need to have an excess of interest to get you where you want to go. So let me get out of the way because you're going to video it. We're going to talk about PSC, but you've got to think about it as part of the family of autoimmune diseases that I look after. So I look after patients who've got a disease of their small bile ducts, and then we call that disease primary biliary cirrhosis, and there's lots of controversy about the name, but the name doesn't matter, okay? That's a disease that is not associated with inflammatory bowel disease, and it attacks small bile ducts. But there are gazillions of small bile ducts, so it takes a long time from the attack, usually, before the liver shows the strain. I look after patients with autoimmune hepatitis, and I'm pleased to say that Martine's been helping those patients get a patient support group, because they haven't had a formal patient support group, and there's going to be a web presence for those, with one of our patients taking the lead. And that's a disease where there's liver cell inflammation. The liver cells, the hepatocytes, are sore because the immune system is attacking them. And that's a disease actually where there's good therapy, but people don't like the side effects of the therapy. And then there's this disease, the one we're going to talk about, sclerosing cholangitis. Primary, because we don't know what causes it. Sclerosing, because it is your bile ducts scarring. So some people call it, cirrhosis of the bile ducts. It's a scarring disease. Cholangitis actually just means inflammation of the bile ducts, but is associated in PSC with infections, because the bile's trying to get out of your liver into your bowel, and if there's a impediment to flow, then there's a risk of infection. No proven therapies, so it is, great opportunities to make a name, but also challenging because it's been so hard over the last 40 years to make the insights that we need. But just look at that disease, and you can see it, and I'll show you later on how it differs from this disease. So that is like a necklace of white cells around small bile ducts, okay? That is concrete around bile ducts. Okay, so whatever therapy we get to you, okay, you can see that just putting a little bit of mild anti-inflammatory on that isn't going to help you. Okay, if you've got concrete down your kitchen sink, just a teeny bit of bleach is not going to get rid of that sort of fibrosis. So we've got very different challenges to how we need to treat this. Realistically, if you want someone to invest $1 billion of their money to give you a new treatment, they want to know that that's a good investment. They want to believe that what I'm telling them is the right way to treat these patients, because largely most of the new drugs coming out for all diseases are based on understanding what causes the disease and how you can interfere, so based on the science. Okay? So what have we done to really unravel the disease over the last 5 to 10 years? I don't want to get in anyone's way. The biggest thing that's happened has been the genetics of the disease. So all disease is complex, and all disease has two facets: your own inherent risk, your genes, and something that you encounter in the environment. The environment is very hard to untangle, because it might be something that you encountered 30 years ago, which then triggered it, and then when you come to meet a clinician, they can't measure what happened to you 30 years ago. But your genes we can measure. Okay, and we can describe all of your different genes and how they differ to people who've not got PSC and how they differ to people who've just got colitis. And so this has been an international effort led from Oslo, essentially. And you should know that that effort has been funded by charity. Okay, so Tom Carlson is in a receipt of 10-year program funding from a family who I think has someone who's got PSC in it. And their donation, and I think the family are equivalent to owning Tesco's, okay? But their donation has essentially funded nearly all of this international effort, which is pretty impressive, and it's a Scandinavian approach to research which is open and inclusive. And we've done lots of genetics, and people have contributed from the UK, North America, all of Europe, and we look to see what genes are related to just PSC, what genes are similar to reasons why you get inflammatory bowel disease. And there's a reasonable overlap with inflammatory bowel disease, but there's a set of genes which are more PSC. The problem is that actually the biggest association is something called the HLA, and that is a black box of immunology, and that is how you present foreign things to your immune system. It's how you essentially stop having infections. And that by far explains most of your risk of getting PSC, and that's what we need to untangle. The other genes are genes that control your immune system and how you respond, and are very subtle, but explain why you're slightly different. The next thing people have done is looked at mice. Now, I hate to tell you this, but we don't have a model of PSC, but again, the pharma industry would like to see that any drugs that we give cure a mouse of something that looks like PSC. Okay? It isn't PSC, of course, in the mouse, okay? But it's pretty reassuring before you give it to a human to have some animal data that it's safe and that has some effect on the disease, because, you know, we don't want to do any harm if we give new drugs. So there are different models of mice that get something that looks like PSC, and that's informed the causes. And some of those models of mice have very toxic bile, and other of those mice you can give them a bit of colitis in their bowel, and then you can get some inflammation in their liver. There are some patients who help us. You all help us because you all help us with the DNA, but there are some groups of patients who have things that are similar, that allow us to tease out what's going on. So as it happens, if you are unlucky enough to have cystic fibrosis, then about 10% of kids with cystic fibrosis actually get bile duct disease. And that bile duct disease actually has some similarities to PSC. It's not the same, it has some similarities. So understanding that has helped us understand some of the ion channels that are important in patients with PSC and how they make bile. Similarly, there are some patients who've got some very rare forms of bile duct inflammation that looks like PSC, but isn't. So they've got an autoimmune form which just vanishes with steroids. It looks exactly the same if you do an ERCP or an MRI scan, but you give them steroids and all vanishes. So that starts to teach us some of the pathways that are important. And there are some patients where things happen after liver transplants where their bile ducts look like PSC. It isn't PSC, but it looks just like it, so it helps us in terms of the blood supply to the bile ducts. And then the last sort of work, which has really been Dave Adams' last 20 years of research, has been trying to understand how is it that 70 to 80% of our patients have got colitis, inflammation in their colon, and have also got inflammation in their bile ducts. And why is it that it appears that white cells that should just stick in the colon are sticking in the liver as well? So why are they reprogrammed to go to the wrong place? And that is driving some of the opportunities for new therapies, because the concept would be, if you're unlucky enough to have the genes and something else changes in your bile ducts in the environment, but if we could stop these white cells sticking in the bile ducts, that would be good, you'd have less inflammation. So that's a strand of research that really Birmingham has been leading on. Okay, so how do you get there? This is a very simple slide, but it's very important, is how patients are diagnosed. Okay? Increasingly, our patients come to us different to the textbooks. So historically, patients would have come to Roger Chapman from the inflammatory bowel disease clinic. If you look at Roger's first paper from the 1970s with Sheila Sherlock, you know, it's a very advanced population of patients with very advanced disease, most of whom have got colitis. So the IBD doctors would screen blood tests and then send you the patient. Now, increasingly, people are having blood tests all the time. So we're picking up the PSC before we pick up the colitis. People are having MRI scans more often for abdominal pain, so we're picking up early bile duct changes. So actually half our patients present with the PSC first, and then maybe we find the inflammatory bowel disease, whereas previously it was more the other way around. But what happens is that your GP or your gastroenterologist sees that your blood tests are slightly abnormal. And the way that they're abnormal is that your bile ducts are inflamed, and we know that by the pattern of the blood tests. It doesn't tell you the severity, it just tells you where to point your investigations of biliary, of the bile ducts. So that's your alkaline phosphatase. So that's why everyone looks at your alkaline phosphatase and says, that's elevated. You've not got vitamin D deficiency, you've not recently broken a bone, you've not recently been pregnant, et cetera, it must be coming from your liver, and that's where they then follow down. And they make sure by scans that there's no other cause, okay? Also, at least 10% of patients now may even have normal tests, okay? That's probably good, but it doesn't mean that your MRI, you haven't got PSC. We don't know quite how well that correlates with what will happen to you forever, but generally the better you test, the better you do, okay? Most of you will only ever have MRI scans, okay? That's a UK practice. There's quite a lot of variation across Europe and the world. If you're on forums and you're asking what people are doing in Heidelberg, they have ERCPs. If you live in Helsinki, you know, one of my colleagues, if you've got even the mildest alkaline phosphatase elevation, the patient will have an ERCP and a liver biopsy. And that's all his patients will get that. So he's not wrong and we're not right. It's a different perspective, a different group of patients. You know, it's just the way that he manages his patients. But in the UK, we'd expect that you'd have an MRI, and we would hope that you'd only have a ERCP, an endoscopy, if you really need it, and we think that there's something that we can change, something to fix. So not for diagnosis. Liver biopsy is uncommon for diagnosis, but will become increasingly common for clinical trials. So we generally don't need a biopsy because the blood tests and the scans will tell us you've got the disease. But the biopsy can help if we don't understand what's going on, if the things don't fit, if people are worried about so-called overlap syndromes, which is something people talk about an awful lot, and whether or not steroids may have a role in your disease. It's going to become more important in clinical trials because, again, if you're going to ask someone to pay £10,000 a year for your new therapy, they may not believe you if you just say it's your blood tests that get better. They're going to say to you, show me that your liver really gets better and show me a liver biopsy that's got less scarring. We don't know what they're going to say, but that's what we predict they're going to say. And then if you haven't already got inflammatory bowel disease, you win yourself your first colonoscopy because certainly in a UK population, 70 to 80% of people will have colitis. Increasingly, because we're diagnosing more women, you should know that women will only have a 50% chance of having colitis. Increasingly, the UK is much more multicultural. The association with inflammatory bowel disease has a sort of north-south gradient. If you live in Japan, PSC is less common, but patients with PSC don't have colitis very often. Okay, so there's a lot to do with your genes and where you're from as to whether or not you have colitis and PSC. So, and the last thing to say is we've got the full spectrum. We've got patients who've developed colitis 10 years after liver transplantation. They had their PSC, they needed a transplant, and eventually the colitis shows its head. Okay, that's because strictly speaking, the colitis of PSC is not really ulcerative colitis. It's not really Crohn's disease. It's so-called PSC IBD. It is its own form, okay? And increasingly we recognize that it's not quite the same. It looks the same. It's got lots of similarities, but it isn't quite the same. Okay. If you want to understand how we might then treat you, which is of course our goal, and not just your disease but your symptoms, you need to compartmentalize what's going on, and this is what scientists are doing, this is what industry are doing, to think about where to give you new drugs. And the compartments you want to think about is your liver cell, your bile ducts, your immune system, and your bowel. Okay? Those are the 4 places where we're going to need to intervene to change this disease. This bit is probably the easiest to understand, but the hardest to intervene with, because there's a subtle difference about autoimmune bile duct disease as there is some other autoimmune diseases. So the fact that it's autoimmune and your immune system triggers the attack doesn't explain all the injury that you get in your liver, because your bile ducts are designed to get rid of a toxic compound, bile, and to get it in the bowel. If you attack your bile ducts through the immune system, okay, the immune system may have started the war, but the war is perpetuated by the bile hanging around, because bile is a detergent. Okay? You don't want bile in your liver because it is designed, to solubilize fat. Okay? So in our diseases, one of the challenges is the immune system is important at some point, But just as important is the fact that the bile hangs around in the wrong place, which explains why ursodeoxycholic acid has been the therapy of choice for a while, even if it probably doesn't help, but it makes your bile less toxic to you so that you can at least cope with the secondary consequences of the inflammation. But within the liver, there are two bits of it. It's in fact your hepatocyte, your liver cell, that actually makes the bile, and it's your bile ducts that channel it out in a safe way. So you've actually got lots and lots of transporters that are pumping in bile, making bile as a product to get out, bile acids, phospholipids, and pumping it out, and then they're going down through the bile ducts and then out the liver. Okay? So actually, it's not, when the liver is poisoned, it's the liver cell and the bile ducts that are poisoned. And then what we've really sort of starting to grapple with is the fact that actually, not only just because IBD is associated with PSC, in fact, the largest organ in your body is the gut and the bugs that live there, and we're all absolutely dependent on those bugs to be healthy. Okay? And it's because of the bugs in your bowel, it's how we've evolved to be successful, as humans. And these bugs are really important in processing all sorts of things. And in fact, there's a very, very clever and just increasingly understood communication between this bit of you, the gut, and your liver. And they're talking to each other with hormones, essentially, enterochines. So there are chemicals that communicate between the two. And in fact, some of the therapies may therefore be focused on your bowel to hopefully improve your liver. It's speculation, but clearly we can see that for all autoimmune diseases, that what's in your bowel is relevant. And it's fascinating because actually, certainly in the inflammatory bowel disease world, it's going to start to explain why some people get colitis. And there's been hypotheses about colitis and Crohn's for a long time. I mean, there's one wacky idea that's been around for decades that Crohn's is due to toothpaste. Okay? So, but it's a teeny bit wacky, but actually now that we know more and more about the genes that give Crohn's, it's not completely off the planet. Okay? Because there are genes and regulated molecules in the bowel that are there to engulf things from your bowel. And if they engulf a chemical particle or in a thing, they respond in a certain way. And if that gene works slightly differently in you compared to somebody else, that could trigger inflammation and that could give you colitis. And so the concepts are going to be complicated, but the environment is going to maybe playing a large role through the bowel. Okay, so those are where we're thinking about targeting therapy. But as I said, this is what makes this disease so difficult and why people need to be realistic about the therapies and why you'll hear me talk about why I need to persuade you to have therapy as early in your disease as possible. Because even by the time I see the majority of our patients, they've already got scarring. And I just told you, if you thought that I could fix your kitchen sink, which is completely blocked and clogged up just by dropping an aspirin down it, you're not going to believe me. And this is the problem, that unlike a lot of diseases, autoimmune diseases, there's a lot of scar tissue around your bile duct. Okay? And that's what you're trying to get rid of. And that's what's blocking the bile from getting out, is that around, your bile duct is fibrosed. And no wonder the bile can't get out. Because the bile can't get out, the liver gets inflamed. And because the liver gets inflamed, it gets scarred. And obviously, eventually, despite the liver being pretty good at healing itself, it comes a point where the liver says, thanks, guys, but I can't keep up with this. Okay? And what we want to hope for is go back and catch patients when there's less scarring and more inflammation, at a point where we hope we can have a bigger impact on preventing the scarring. The next thing to say is, whatever you believe about ursodeoxycholic acid, and I know there's lots of different views about it, and I know it's a very controversial topic. You can just take the simplistic approach and say, well, look, if it worked, we'd know by now, okay, after 30 years. But I don't know is the answer. But if it's been that hard to prove that it's only helping a small number of people, it can't be helping the majority, can it? Okay, so there's a role for it. I'm making fun, but I mean, there's a role, but it can't be the wonder drug. Otherwise, it would be really easy to prove it was effective. You wouldn't have so many trials. But you needed the trials to learn more and more about it. And this was a very brave trial. This was a trial by Keith Lindor, who is one of the leading experts on PSC in the world. And he was at the Mayo in Rochester. He's now in Arizona getting the sun. Okay? But everyone said, urso, safe drug, must be the reason it doesn't work in PSC. We're not giving enough. We're just idiots, aren't we? Give more, okay? But he did a trial, and he actually persuaded the NIH to fund it, which is a big thing, because it needed about 6 centers to do. And in this trial, it didn't work, okay? That was obvious. But more than that, at high dose, so we're not talking about normal dose, at high dose, 28 to 30 milligrams per kilogram, he got a phone call one day from the Data Safety Board, which is something you have on all clinical trials, to say, we're stopping your trial. And he said, great, I've cured it. And he said, no. And they said, no, it's dangerous. Okay? And they weren't expecting that. But you have to do the trial to find out. Otherwise, because URSO was so easy to give, everyone was doing what the Mayo was doing. So there were places around the world that weren't doing the trial and saying, well, if the Mayo are now giving 28 to 30 milligrams per kilogram, I'd better get on and I better also increase my patient's dose of URSO from 20 milligrams per kilogram. So everyone was saying, well, they're doing a trial, it must be all right. I'll increase the dose now so my patient doesn't have to miss out. But in fact, this dose was not good for you. Okay? You have to have evidence to treat your patients correctly. It's hard, it's going to take time. You know, this is a study that took many years to complete and still only had a couple of hundred patients, which is nothing compared to a study in heart disease, which will have 10,000 patients. But if you don't do the trial, then you're going to walk around with your eyes half closed and you may have therapy that's not good for you. Okay? Even if that therapy seems obvious, even if that therapy seems simple to take, and even if that therapy has few side effects overtly, you only find out the truth when you actually do the study. Okay, so there's no way around the fact that you've got to try your best to have good evidence. The next thing to say is that we don't know what your blood tests mean. Broadly speaking, okay, you don't need to worry about the details of this graph, but broadly speaking, if your blood tests are better, that's good for you. Okay, and that's because it means there's less bile duct inflammation. But it doesn't matter whether your blood tests got better because of URSO or just because they were better. Okay, so URSO drops your blood tests. There's no doubt about it. Okay, but it's not the URSO that has any impact on whether you do better or not. Okay, so if you take URSO, these two graphs show you this. So you've got patients, basically, if you respond, if you've got good blood tests, you do well. If you've got bad blood tests, you do worse. And it doesn't matter whether you had URSO or didn't have URSO to get there. Okay, so your blood tests do predict what's going to happen to you, but the fact that URSO made them drop didn't make a difference. Okay, it's not the URSO that's relevant. All it's probably doing is choosing a different group of patients that you are. So it's highlighting that you were in a better group to start off with. Okay, so there's our challenge, but it also is an opportunity because we can say, well, perhaps if your blood tests are good, maybe you're less likely to need another drug. And perhaps we should focus our efforts on the people who really don't have good blood tests so that we've got a greater chance to show that our drug works, okay? Because they're the sicker group and it'll be quicker to show that something works for them, okay? So, how should we fix you, okay? Well, the concept goes, whether we're right or not, time will tell, maybe we should fix your immune system, okay? So there's an awful lot going on in inflammatory bowel disease. There'll be some of you who get, lots of different biological therapies for Crohn's or colitis, which works. It's revolutionized the treatment of inflammatory bowel disease. I remember how different it is because when I was SHO at the Hammersmith in 1998, I think, the only anti-TNF therapies were just coming in, and I was working for a guy, and we flew in infliximab for a patient, and I had to give it. Okay, whereas now, of course, you go to a day unit, you inject it at home, or the nurse gives it. It's just widespread use, and that's approximately how long it's taken to sort of change inflammatory bowel disease. But maybe that's what we need to give you, something that's better for your immune system. Maybe we need better bile acids. So URSO clearly does something to your bile because it improves your blood test, but obviously not enough. So maybe we need a better URSO. NOR-URSO is one example. I'll talk about obeticoic acid, another example. Maybe it's going to be fiddling with your bowel. Maybe, I'm sure it'll come up in the questions and answers. Maybe antibiotics are the answer to this disease. If you change the bugs in your bowel, maybe that will help to reduce the inflammation. And then some of you will know about clinical trials of fibrosis. So within liver disease, there's lots of efforts just to treat the fibrosis part of the disease. Forget what causes it. If you at least get rid of the fibrosis, that's better for your patients, because it's true, the majority of patients with PSC will be transplanted because of cirrhosis. So if they had less cirrhosis, they will live longer, which is what, as a patient, you don't really mind so long as you live longer. It doesn't matter which bit of the journey that we've helped you on. So there's an effort around fibrosis, and there's clinical trials going on there. Okay, So we can talk about NOR-URSO is a trial that's going on run by Falk, and that's a side chain modified ursodeoxycholic acid, and that's in phase 2. And that's going on in the UK and Europe, and we're contributing to that, and that's very exciting. Okay, and I'm sure there'll be a phase 3 trial. But actually, the reason I've got this slide up is to tell you that there is actually hope in the sense that this is a drug that's particularly been used for PBC. There have now been trials in phase 2 and phase 3. And why it's exciting is that it can show that you can go from mechanism, so they made a drug which was better than URSO by fiddling with it in the lab, which they thought would have better effects on your bile acids, and they are close to getting a license for it in 2015 for PBC. Okay? And if they get a license for it for PBC, naturally we'll do trials in PSC, but it shows you can go that full journey, and they started off as a small company with 5 people, and then sometime this year they were employing 50 people, and now they're employing 200 people, and now they're worth $10 billion. Okay? Because of the potential, not just for PBC, but for other diseases. So you show that you can make inroads, and there is hope that there will be new drugs for bile duct disease. And this drug is the one that's likely to be on the market for PBC, and they want to do a trial in PSC. And it's essentially works in a similar way to URSO, but it's more powerful, and it's a better way of improving your bile flow. Okay, but what's optimistic about it is that you can actually do it, and you can actually go the full circle, and they're now just to the point where they're going to ask the FDA, because I'm afraid it's what America says which really counts, can they give it to patients, can we just basically buy it off the shelf? So that will benefit everybody. I touched on NOR-URSO, but let's move back to the immune way of tackling it, so you can also think about some of the trials that are going on starting in Birmingham and then around the UK as well. And I teased Dave, but we'll call it the Adams hypothesis. Okay, and it's not just his idea, which is important because you always want to have consensus in science, but in essence, it's all about stickiness. Okay, these lymphocytes, these white cells, are meant to stick in go back to your bowel, or at least they do it in inflammatory bowel disease. But then what happens is when you look in patients with PSC, they've got the same signature of those white cells in their liver, and they're sticking to their in their liver, causing inflammation. So you can see the concept is, well, let's make them less sticky, okay? Then they'll skip your liver and just keep going around in a circle until they get tired, okay? And the exciting factor is that there is evidence that if you block alpha-4 beta-7, just a name of a sticky molecule, in Crohn's disease, it works, okay? Why that's exciting is because of the truth. A lot of the drugs that you're going to want to get, you hope are going to be proven to work in a bigger, more common disease, because vedolizumab now looks like it will make the company money. If it makes them money, then they're prepared to do a trial in PSC. Okay, and they are. And they're going to do a trial starting at the end of the year, okay, which will be an international study. So it's likely to at least be a study that may have a chance to answer the question. It won't be 50 people, it'll be 200 or 300. Okay, and that's big by PSC standards. So that's important that people are prepared to do it. We're going to start a study at the end of October, November time, where we block another molecule that Dave's worked on called VAP1, okay, again with the idea that we stop your lymphocytes being sticky. Okay, and we've just got funding for that. That'll be a smaller study. By our standards, it's a big study. We're going to be looking for 45 to 50 patients, but it's really to see whether there's a proof of principle, whether it benefits, whether we can, because the company that makes that is a teeny little company in Finland, okay, that we've been working with, so they live year to year on how much money they can raise from venture capital, okay, so we're doing it as a partnership with the UK government and that company, okay, to sort of defray the costs, because otherwise they'd say, why do it, we'd rather treat Alzheimer's. Okay, so you've got to persuade, you've got to have a model that works so that everyone's happy. The other thing that's on the horizon is you can take the what's the way to approach this? You could say, look, it's all far too complicated, all these clever ideas about what causes the disease, but fundamentally there's too much inflammation in my liver. How about if I use stem cells? So this isn't necessarily using stem cells to regenerate your liver, which is a completely different talk and not the area of our interest, but this is using some stem cells that are called mesenchymal stromal cells as anti-inflammatory sponges. Okay, so essentially if you infuse these cells, and you can get them from blood donors, and you basically clean them up and make them specific, they are anti-inflammatory in animal models. And it doesn't really matter what the inflammation is due to, they tend to turn off the inflammation. So that's quite appealing for PSC, which is very complicated, that maybe we should forget about the details and just say, look, you just need better anti-inflammation in the liver. So we're going to try a trial, hopefully in 2016, funded by the European Union, so it's pretty good. It'd be better if we didn't leave the European Union if you've got PSC, okay? Because they've given my colleague 5 million euros to do the study, okay, which the UK weren't going to give us, okay, to try and see whether this kind of therapy will help patients with PSC. It's not going to be just about PSC, but it's about all diseases, but it's an opportunity about stem cells, okay. And then this is just a diagram to remind you that I mentioned about the bowel. Okay, and there's lots of stuff in the literature about whether I should give all of you vancomycin. Personally, I don't think I should, not yet. I don't think you'd want to be on an antibiotic for your entire life. I think you will have heard, the chief medical officer tell you that, in 10 or 20 years' time, the antibiotic resistance is going to be killing you. And I can tell you that from my liver transplant practice, it's a huge issue for us already in Birmingham. Okay, we have patients who die because there are no antibiotics. Okay, they get to the point where we no longer have an antibiotic for their bug. So whilst it's appealing to give antibiotics to treat this disease, and whilst there is some data that suggests, particularly in kids, it makes a difference, and whilst there is some logic behind it, we've got to be very careful before we tell you to take an antibiotic for, you can work it out. It wouldn't be a 2-week course, would it? I mean, this disease is a lifelong disease, it's chronic, so we've got to be very careful before we suggest you're on antibiotics forever, because antibiotics are precious, okay? And they've made a huge difference in modern medicine, and it's a real challenge to get new antibiotics. There are not many new antibiotics coming. But your bowel does all sorts of clever things. So, for example, your bowel breaks down fiber, okay, and it makes free fatty acids, and those fatty acids talk to your immune system, okay? So it starts to show you how there's that link between your bowel and your immune system. So this is really relevant more to colitis per se, but how your bugs in your bowel eat up the fiber changes the way that your immune system works in your colon. So you can see why, the bowel is so intimately linked to autoimmune diseases. Okay, the last thing to mention is that maybe, but this is also some way away, we could also think a little bit outside the box. I mentioned that in the UK we don't do much ERCP. There are some centres that do more than others, okay? But increasingly, there is actually better and better telescopes that you can stick up people's bile ducts. There's something called the spyglass, where basically it's a teeny fibre which has got optical fibres down. You can actually go all the way up your bile ducts and have a look inside. I mean, this is magnified hugely. Remember, your common bile duct's normally only 5 millimetres, and that's the biggest bile duct coming out. So on average, it's less than 10 millimetres. But there is some sense to thinking, particularly because on everyone's mind is the risk of bile duct cancer, that maybe we need to be doing therapies where we go into the bile ducts and drop the therapy on the bile duct, actually where the disease is inflamed. And there are people around the world who want to improve so-called cholangioscopy, and it's not impossible that might become a therapy that's logical, so long as it's safe. Remember, the reason we're very cautious about ERCP is, we don't want to introduce bugs into a system that's already got risk of bugs, because once bugs are there, they're very hard to get rid of. Okay, and you can get trapped into the cycle of cholangitis and needing antibiotics, and it can really be a challenge to get you better. Okay, and the best thing to make people better is to stop fiddling. Okay, and unfortunately, what happens is that people have their first ERCP, then they get cholangitis, then the doctor does another one and another one and another one, and in fact, all they're doing is making it worse. And if they just stood back and took a deep breath and were brave, at least then the patient would, have the chance to clear their own system. Okay, but it's something to bear in mind about, therapies for the future. Okay, so if I summarize some of the things I've said before we talk a little bit about clinical trials, okay, what do I think about URSO? Everyone wants to know what I think about URSO. The truth is there's no clear benefit, okay? There's a risk of harm if you take too much. Don't object if people take it as long as they understand the evidence behind it, okay? But, the truth is also if this came along now, and you've all heard of NICE, and they're the people who say whether the government would pay for a drug or not, I guarantee you that NICE would not pay for URSO in PSC. There's no way in hope. If they won't pay for some of the other drugs that got even some benefit, in cancer, okay, they're going to look at the data on URSO and say, you've just shown me, that you need to do, what they'll say is you need to do a bigger trial, okay? But that, fortunately, this is all history, so it is paid for, but don't lose any sleep if you don't take it. And a lot of my patients are not taking it from the outset, so they're ready for clinical trials. I don't think it really reduces your risk of cancers, by the way. It's complicated about whether you've got features that look like autoimmune hepatitis. I think the way to think about PSC is that you're all slightly different, and don't be surprised if a young person has a different course to an older person. And a young person who presents with PSC is classically very inflammatory, okay? And then over time it morphs towards what looks like PSC. And we see that a lot because, James is not here today, but we transition all the patients from the Children's Hospital, okay? And so, we want to look after them until they get to 80, but we see what happened to them when they were 12 or 13 and it looked very inflammatory. And then when you look after them for 10, 20, 30 years, their disease simply becomes PSC, becomes the concrete disease. So we're very cautious about steroids because steroids have side effects, and those side effects are important. People are very concerned about missing IgG4 disease. It's very rare, okay? It's real, okay? It's worth looking for, but in my experience, certainly since I've been here, in Canada I looked after about 50 to 60 patients with IgG4 disease. In the UK, there are 2 centres that are interested, Oxford and UCL. And since I've been in Birmingham, I think I've diagnosed only 1 or 2 patients. Okay, so it's vanishingly rare, it's insightful for science, but in reality, it's not going to change practice, okay, for the majority of you. It certainly gives us ideas about maybe there are subgroups of patients who could have more steroids, but we don't know yet. This is something that's very important to patients and something we're working on, pruritus and fatigue, okay? So itch, that's what the pruritus is, the medical term, is a devastating symptom. It's absolutely awful, okay? It's like having ants under your skin, okay? And you can't see the ants and you keep scratching. We see a lot of itch in both PBC and PSC, and there are new drugs coming on the market for itch, and we have a trial going on for PBC, and we think that drug will be tried in PSC. And I think it will improve your itch, and it may even improve your disease, which is actually also quite exciting. Okay, so there are things on the market. There are trials even for fatigue now going on in PBC, giving powerful biological antibodies. So in Newcastle, we're giving rituximab, which is a drug that's been used in lymphoma for patients with fatigue. Okay, because it's real. Okay, everybody's different. For some people, it's not an issue. For other people, it's devastating. Okay, I've talked a lot about endoscopy. If you're going to have it, just make sure the person knows what they're doing, and please, 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 please make sure they don't forget your antibiotics. Okay, that's really important. Okay, personally, I think any PSC patient having an ERCP should have some antibiotics. Okay, transplant we can touch on if people are interested in. It's a good answer to a current challenge. Okay, it works very well. It's not a panacea. I always tell people it's a liver transplant, not a life transplant. Okay, we're just changing your liver. We're not changing your body. Okay, but there'll be people in the room who know full well that, unless they tell someone, they don't know that the other people don't know they've had a transplant. Okay, so, it's not perfect by any means, but it makes a huge difference to our patients. And then the other thing I always very, very keen on, which gets forgotten a lot, is please make sure you have an ultrasound at least once a year. Okay, I don't know how often you should have an MRI scan, no one knows. Okay, and MRI scans are actually very difficult to interpret, even in a good centre like Birmingham, but an ultrasound is very important.